Hello everyone, welcome back to my YouTube channel, Pathology Academy. In today's video, I will be talking about emphysema. So let's get started. Emphysema is defined as permanent enlargement of the air spaces distal to terminal bronchioles with wall destruction. It's a progressive lung disease, part of a broader category of COPD, characterized by damaged lung tissue and difficulty in breathing. It involves the destruction of the walls of the tiny air sacs or alveoli in the lungs, leading to larger, less elastic air spaces and reduced ability to exchange oxygen and carbon dioxide. The etiology are smoking, pollution, dust exposure, and alpha 1 antitrypsin deficiency. Emphysema is classified into four types: centrilobular, panlobular, paraseptal, and irregular. As I have described, according to the anatomical distribution within the lobule, the emphysema has been categorized into centricyanid, panacyanid, paraseptal, and irregular forms. You can see here I have shown an acinus which consists of a respiratory bronchial alveolar duct, alveoli. In this, you can see in century acinar type, the central part of the acinus is involved, that is, the part involving respiratory bronchiole is involved. In pan acinar, the whole of the acinus is involved. In paraseptal, the periphery of the acinus is involved. And in irregular types, the distribution is irregular, associated with scarring. The factors which contribute to the pathogenesis of emphysema are protease antiprotease imbalance, inflammatory response, oxidative stress, and alveolar wall destruction and loss of the elastic recoil of the wall. The pathogenesis, as you can see here, in patients who smoke, in people who are genetically predisposed or exposed to pollution, there is damage of the respiratory epithelium and release of inflammatory mediators like leukotriene P4, interleukin 8, and TNF. These mediators act as chemotactic factors and amplify inflammation, including structural changes. Also, the oxidants causes tissue damage, endothelial dysfunction, and inflammation, leading to destruction of the alveolar wall. The smoke contains the smoking increases the activity of neutrophils, and it causes release of proteases which also contribute to the destruction of alveolar wall. In patients with congenital alpha 1 antitrypsin deficiency, there is protease antiprotease imbalance, which also causes destruction of the alveolar wall. And all of this contributes to emphysema. In this flowchart also I have explained the same thing, that how the exposure to smoking in genetically predisposed individuals and individuals with alpha 1 antitrypsin deficiency, how oxidative stress and inflammatory cell activation cause protease antiprotease imbalance and alveolar wall destruction, leading to loss of elastic recoil and air trapping. A patient of emphysema will present with dyspnea, minimal cough, weight loss, and barrel chest. The signs are decreased breath sounds, hyperresonance, and prolonged expiration. The investigations done for emphysema include chest X-ray, which shows hyperlucency and flat diaphragm, HRCT, which identifies the type and extent, pulmonary function test, ABG, and serum alpha-1 antitrypsin can also be done as investigative procedures. This is a micrograph of emphysema, and as you can see here, the enlarged air sacs and disruptions of the alveolar wall. For management, smoking cessation, pulmonary rehab, and vaccination should be done. Treatment with bronchodilators, corticosteroids, oxygen therapy is required, and if surgery is required, then there are different options available as described here. The complications of emphysema are cor pulmonale, pneumothorax, respiratory failure, and recurrent infections. Prognosis. Well, emphysema is a progressive disease and it can be slowed by smoking cessation.